Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Continuing on, we are on drugs 156 through 160. Also want to remind you guys, top 200 drugs. It's a great study guide, absolutely free PDF, 31 pages at reallifepharmacology.com. Simply an email will get you access to that. I've highlighted a few of the most important things that you're likely to see in practice, as well as on board exams, pharmacology exams, and things like that. So go check that out. Free resource for you. Simply an email will get you access. All right, getting into the drugs of the day today. 156, we've got niacin. Brand name is Niaspan. This drug's fallen out of favor a little bit over time here. It's also known as vitamin B3, and mechanistically where this is used for therapeutic purposes other than potentially nutritional deficiency, it can help lower cholesterol, and it does this by inhibiting triglyceride formation. It's not totally understood how that works. But if you've got a patient that's kind of, resistant to other therapies, or it's not working, or it's not tolerable, let's say like a fenofibrate, for example, is a commonly used medication for very high triglycerides. If that's not working, niacin may be a potential option. And the dosage form Niaspan is an extended release dosage form that may be a little bit better tolerated. In addition to those effects on triglycerides, it may help increase HDL. That's considered the good cholesterol, where LDL is the bad cholesterol. It may help increase that HDL. So a few patient populations or a few adverse effects that I think are important to note here. So GI upset, so patients that have trouble with that, tolerating medications, niacin can definitely cause some stomach upset, some nausea, that type of thing. It also can raise uric acid levels. So in patients with gout, we need to be really, really careful of this. I don't know how many times I've seen, the prescribing cascade cause new prescriptions for gout. So thiazide diuretics are one common example, and another example is niacin. Niacin can raise uric acid and potentially increase the risk for gout flares and increasing in new medications then to manage gout. So pay attention to that for sure. The number one side effect, probably the most commonly tested adverse effect, I would say, with niacin is flushing. So kind of this redness in the face, warmth feeling in the face. And it is actually reported as upwards of 50% plus. So it is very frequently encountered. Typically, the risk of this is going to go up as you increase the dose. It can be helped by giving aspirin with it. In my opinion, it's not done very often, simply for the fact that aspirin has plenty of challenges there as well. But that is a potential option to kind of relieve that flushing adverse effect. The other potential way to reduce that flushing effect, or I should say commonly used way to reduce that effect, is to use the extended release product, where it's released more slowly and you don't get those rapid high concentrations, which may increase that risk for flushing. From a drug interaction standpoint, I think about gout medications, so niacin could, kind of directly oppose what we're trying to do with gout medications and lowering uric acid. So allopurinol is a great example. Again, if you see frequent gout flares and the use of NSAIDs or corticosteroids to treat gout flares, make sure they're not on niacin. That could worsen that. Alcohol is another one I wanted to mention with drug interactions. That flushing effect can be increased with alcohol. It can be caused by alcohol itself, of course, if you've drank too much or if it bothers you that way when you take alcohol. That can certainly have some additive effects if we're on niacin as well. Oppose diabetes medications, so I wouldn't call it a huge effect typically for most patients, but niacin has been shown to potentially modestly raise blood sugars. Again, this is kind of dose dependent. It's not something I crazy worry about, but if you start niacin, see it started, and then shortly thereafter you see an increase in diabetes medications or lack of control of blood sugar, it certainly should be on the radar there. And then statins, there has been some evidence saying, hey, this might increase the risk for statin toxicity such as muscle pain, soreness, and rhabdomyolysis risk. Next medication is 157. It is alfuzosin. Brand name is Uroxatral. And this medication is an alpha blocker. So it blocks alpha receptors, which ultimately causes smooth muscle relaxation, vasodilation, and ultimately opening of the ureter. That's what we're trying to do with this medication. It is used for symptoms of BPH and basically allowing patients to pass urine more easily. So again, primarily going to be used in male patients. Probably the more commonly used medication in this class is tamsulosin. Brand name is Flomax, but I certainly have seen alfuzosin used as well. Remember that non-selective alpha blockers can be used for hypertension and BPH. Alfuzosin is a selective alpha blocker. It's really meant to target that bladder tissue, that ureter tissue with the way it works in the smooth muscle, kind of in the genitourinary area. So it doesn't have as much effect on the vessels as, say, terazosin or doxazosin or prazosin. It can work quickly to help relieve symptoms. So this is different than the 5-alpha reductase inhibitors like finasteride, which is commonly used for BPH, or dutasteride is another example. So Uroxatral actually works much more quickly. So that is a nice benefit if patients are having a ton of urinary retention associated with BPH. Orthostatus, so as you escalate doses, or maybe some patients may be more sensitive to this medication, you can start to touch those vessels and open them up, which can increase the risk for orthostasis. Or if a patient's on a bunch of other medications that contribute to orthostasis, maybe adding this medication on top of that kind of puts them over the top and drops their blood pressure too far. So bottom line, good idea, particularly when starting or increasing dose, to keep tabs on that blood pressure a little bit and making sure patients aren't reporting dizziness or dropping too low. And then lastly, I wanted to mention alpha blockers can increase the risk of floppy iris syndrome for those undergoing eye operations. So this is a good example of a medication to either educate your patient, say, hey, if you have any eye operations, procedures, anything like that, be sure you discuss that with your ophthalmologist, okay? So very, very important education point there. Finishing up with drug interactions, so I think about blood pressure lowering medications, so any antihypertensive, of course, but medications like PDE inhibitors, PDE5 inhibitors, like sildenafil, for example. Avoid other alpha blockers. So I state this, hopefully most most providers would understand that it shouldn't be used with a medication from a similar class or the same class. However, I've seen these agents used together more than I would like to admit. So typically what happens is, maybe an older patient's been on an alpha blocker for hypertension for a really long time. And then, maybe they're having worsening symptoms of urinary retention, often due to anticholinergics. But anyway, I'll save that for another podcast episode. But anyway, I have seen duplicate alpha blockers where we're using a non-selective and a selective. And, I always encourage, if that non-selective is indicated, let's just keep them on that one and adjust the dose accordingly. For their BPH symptoms. So can be a challenge and definitely an area where I've seen some duplication where we use a non-selective alpha blocker with a selective alpha blocker like alfuzosin, for example. Other drug interactions to think about, CYP3A4 inhibitors actually increase the concentration of this medication. So grapefruit juice is kind of a classic example. And the last example we'll tie into the next med is clarithromycin. So it's actually recommended to avoid this combination if possible. So moving on to clarithromycin, this is a macrolide antibiotic. Brand name is Biaxin, and it has a ton of drug interactions, which I'll get to coming up here. But it's used to treat H. pylori, a bunch of different things. Basically anything a macrolide can treat, azithromycin, erythromycin. Clarithromycin is going to have that coverage, or at least very similar coverage to that. The most common situation I probably see clarithromycin used specifically is in H. pylori. So that's treatment of stomach ulcers due to that particular bacteria. We've got evidence supporting its use in that setting. But can be used for pneumonia, an alternative for otitis media, MAC, so that's Mycobacterium avian complex, pertussis, whooping cough, can be used for treatment of that as well. But typically we're going to use probably azithromycin. It's a little bit easier dosing and probably less risk for drug interactions with azithromycin compared to clarithromycin. Now, mechanistically, how do these work? It binds to the 23S ribosomal RNA molecule of the 50S subunit, which ultimately stops the bacteria from producing protein or creating protein, which is necessary to continue to live and proliferate and all that good stuff. Adverse effect profile, as with most antibiotics, GI adverse effects are prominent. QT prolongation has been reported. There's rare liver concerns as well. But again, getting back to drug interactions, this is really the primary reason, at least in my experience, why clarithromycin tends to be avoided compared to using azithromycin. So those drug interactions specifically, it inhibits CYP3A4, and it's a strong inhibitor of that. So alfuzosin I alluded to as a classic example, but there's all sorts of medications. Alprazolam, a benzodiazepine, amlodipine, Pixaban, which is an anticoagulant, very high-risk medication or higher-risk medication. Torvastatin, there are some antipsychotics that have some CYP3A4 pathways, some corticosteroids that do, some seizure medications. So again, tons of medications use that CYP3A4 pathway for breakdown. So when we inhibit CYP3A4, the concentrations of those medications are going to go up, and we're going to potentially run into toxicity. In addition to CYP3A4 inhibition, QTc prolongation is something I think about, with the macrolides in general, and probably something you should think about there as well. So, and sometimes it can be a double whammy where you get medication that its concentrations are raised because of CYP3A4 inhibition, as well as the drug interaction causes QT prolongation as well. So it can kind of be a little bit of a double whammy there. So wrapping up clarithromycin, must know that it inhibits CYP3A4. That is definitely going to come up on board exams, pharmacology exams. And speaking of board exams, go check out meded101.com/store. Whether you're taking BCPS, NAPLEX, ambulatory care, geriatrics, tons of information for pharmacists, pharmacy students that can help you pass your board exam. So go support the sponsor, meded101.com/store. Get some great study materials, help you prepare for your exam, and help this podcast, support this podcast as well. Greatly, greatly appreciated. Moving on, we've got drug number 159. This is zolmitriptan. Brand name is Zomig. This is used to treat migraines and potentially cluster headaches as well. Most often I see it used for migraines. It's a selective 5-HT1 receptor agonist, which potentially helps with vasoconstriction that may contribute to some of the headache symptoms that are experienced in migraine, for example. Now, with migraine treatment medications, the dosage formulations are important. So the big thing with migraine is a significant number of people do have nausea and can actually vomit associated with their migraine. And so naturally giving an oral tablet to somebody who's nauseous, has stomach upset, potentially going to vomit, that can be a significant issue because you're not going to absorb the medication prior to them vomiting and getting rid of it, and or you'll make their nausea even worse than it is potentially by giving a medication maybe on an empty stomach, for example. So Zomig has a nasal option, which is great. We're not going to vomit, or I should say vomiting is, typically not going to affect the absorption of that medication if it's given nasally. There's also an oral disintegrating tablet option as well, which maybe allows for a little quicker absorption inside the mouth there as well. Triptans in general, they are the first-line therapy or abortive therapy for the treatment of acute migraine. Adverse effects, you can have some CNS changes. You may have some patients kind of report, kind of a mental fogginess, that type of thing. Dizziness has been reported, maybe some chest pressure even at times. And again, meant for acute relief of symptoms. We're not giving this medication on a daily basis to prevent headaches. This is meant for acute relief of migraine pain. In patients who have uncontrolled blood pressure, ischemic stroke, significant heart disease, prinzmetal angina, and pregnancy, it's generally avoided in those patient populations. Again, we may have to do kind of a risk versus benefit type of thing depending upon their diagnosis and disease states, as well as what other options are available and successful in treating their migraine. So there's always going to be that clinical decision making and discussion with the patient. But again, those patient populations, it's a little bit riskier to use a medication like Zomig. Now, Zomig is or can be used in combination with other analgesics such as acetaminophen or naproxen. With migraine, naproxen in combination with triptans has probably been the most studied. So that may be a potential option in patients that are getting partial response, or maybe we want to use a lower dose. And then, combine it with another analgesic. So keep in mind that's a potential option there as well. Obviously, barring a patient doesn't have a contraindication to an NSAID like naproxen. Drug interaction standpoint, probably the biggest thing I worry about is the serotonin interactions. Not something that's crazy high on my radar, but if you've got a patient that is on, moderate to higher dose SSRIs, maybe they're on a tramadol, maybe they're on an MAOI inhibitor, we've got to pay attention to that because that increased risk for serotonin syndrome is definitely a risk. So again, pay attention to kind of that serotonergic load and the other medications that a patient is on. Last medication, number 160, is canagliflozin. Brand name is Invokana. This is used for type 2 diabetes. I would say in my experience, it's fallen out of favor a little bit compared to empagliflozin or dapagliflozin. Those are probably used a little bit more commonly. By inhibiting sodium glucose cotransporter 2, this results in an increase in glucose excretion through the urine. So that's how these drugs are lowering blood sugar, is through the urine. Glucose goes out through the urine, obviously comes out of the bloodstream, and we get lower blood sugar. Now, what do we got to pay attention to? Adverse effects, precautions. So when you pump glucose out through the urine, you're obviously creating a more suitable environment for growth of bacteria and bugs. So there's an increased risk for genitourinary infections because we're basically giving them food or fuel, if you will, for some of those, bacteria and other bugs. Also, risk of hypoglycemia, certainly that's increased when we use insulin or sulfonylureas with this medication. Also, with that glucose, there may be fluid that's going with it. So in patients with, pre-existing low blood pressure issues already, maybe they're at risk for dehydration. It could potentially worsen that. So good things to pay attention to there. Hyperkalemia has been reported, as well as potential increased risk for euglycemic ketoacidosis, where blood sugar levels don't go crazy high. They can stay actually under or at or around 250 or less. And patients can still experience ketoacidosis, whereas typically under normal conditions, usually those blood sugars are going, 400, 500, 600 plus to get into that ketoacidosis state. But with these medications, that can potentially happen with lower blood glucose levels. So again, something to think about there. Some kind of rare things that can happen. So there's caution on bone fracture risk. There's also some conflicting evidence on risk on amputation. So again, things to think about depending upon that patient history there. From a compelling indication standpoint, we've got some cardioprotective effects with this medication, particularly in patients with ASCVD and diabetes, as well as renal protective effects in patients with diabetes. The A1C lowering effect, so that's how much it lowers those blood sugars, is in the neighborhood of 0.5 point to a point. Again, kind of depend upon the dose and how much success we have there. Again, that's kind of an average. Some patients may, experience a much greater drop, some maybe less, but that's kind of the ballpark average, 0.5 to 1 point with this medication. Finishing up, drug interactions. So think about sulfonylureas and insulin. That hypoglycemia risk may increase. That hyperkalemia risk, think about ACE inhibitors, ARBs, spironolactone. That might add to that effect. Trimethoprim, another kind of unique medication within Bactrim, an antibiotic for infection, that may have some potassium elevating effects. And then I do think about diuretics as well as frequent use of antibiotics, where we're maybe feeding into a genitourinary infection if we're giving it sugar and it's continued to be able to grow because of that basically more freely available sugar coming out of the urine there. So on the diuretic side, think about that volume coming out may kind of have an additive effect where we've basically got, let's say, furosemide on board, and then we add Invokana, which has additive kind of fluid loss effects. We could potentially increase the risk for renal problems there and dehydration. All right, well, that's going to wrap up the podcast for today. If you found this episode helpful, please support the sponsor, meded101.com/store. All the books, resources, everything there goes directly to support this podcast. I greatly appreciate that. Leave us a rating review on iTunes. Share us with friends, colleagues, students. Go get your free PDF, 31 pages on the top 200 drugs. Great little refresher for you to have if you're out in practice or if you're going through pharmacology classes in school. If you want to reach out to me, comments, suggestions, Eric Christensen, PharmD, BCPS, BCGP on LinkedIn. You can also track me down by email, which is probably the preferred route, mededucation101@gmail.com. Thank you so much for listening. Take care, and I hope you have a great rest of your day.